Hello, I'm Ann Peters from the University of Southern California, and I'm joined today by Peter Rossing from the Steno Diabetes Center in Copenhagen. Peter, you gave the Edwin Bierman lecture at the ADA this year about linking kidney and cardiovascular complications. Could you go through a little bit about what you talked about and then what you think is clinically important, both in terms of biomarkers as well as sort of the new clinical treatments that look at reducing cardiovascular and kidney disease risk?
Well, yeah, it was really a pleasure, and I'm very happy that this year at ADA there's a lot of focus on both cardiovascular and renal complications. I think it's a very important topic. I was talking about both the epidemiology, how having diabetes is not a very good prognostic, but if you add on top of that kidney disease, well, that increases the risk for cardiovascular complications, both myocardial infarction and heart failure. And therefore it's important to look out for kidney disease. It's a kind of like modifier, and you have this triad of adverse diseases, diabetes, kidney, and cardiovascular. And then what we have been looking at is that there's this epidemiological link, but there's also a lot of the biomarkers we can use to predict kidney disease or predict cardiovascular disease that are actually shared by these two complications of diabetes. Of course, glucose is important, but we also looked at, for instance, uric acid, which was debated yesterday at the meeting as a potential risk modifier, and we are involved in a trial trying to target uric acid. But I think what we as clinicians can do right now back home is to measure urinary albumin excretion rate and estimate renal function in our patients, because if albuminuria goes up or GFR goes down, then the risk for both mortality, cardiovascular and renal events really go critically up. And we can do something about it, but I think we need to measure this, and I think from recent data, this is not happening, not in Europe, not in the US, overall at least, and that's something we need to really improve on. But in addition to urinary albumin excretion rate and GFR, which is kind of like the markers that we can use in the clinic today, I also talked about some potential markers, you can say, for the future. We talked about markers of fibrosis, because I think fibrosis is a shared biomarker for both kidney disease and cardiovascular disease, and also suggesting that we should target fibrosis in treating cardiovascular and renal complications. So we have worked with blocking, of course, renin-angiotensin system with ACE inhibitors and angiotensin 2 receptor blockers, but also with blocking aldosterone, and that might be a good thing to do. And yesterday I had a talk about finerenone, which is a new compound blocking aldosterone, maybe without giving potassium problems, which is being tested in large outcome trials right now. So that would be interesting to see. But So I think that actually the cardio-renal, you can say, biomarkers can be used to indicate risk, but also to give us some advice on new treatment options.
Can I ask you sort of a basic clinical question? So when you say measurement of albuminuria, do you mean the spot test, or do you mean a 24-hour collection? Because some people argue one way or the other. What, for a clinician, not a researcher, a clinician, what do you say we should be doing?
Yeah, for many years we kind of like swore you need to do 24-hour urine collection. That's the best estimate you get, or evaluation. But in everyday practice, we only do spot urine testing, and that's kind of like reliable. It has as good predictive value as on kidney and cardiovascular outcome, and it's much easier for the patient to do that. So that's what we recommend. You can do, as you say, in a research setting, 24-hour collections. You can collect and also evaluate sodium intake, protein intake, and so on. You might get a better assessment. But on the other hand, usually when we talk about creatinine clearance, measuring creatinine and collecting urine for creatinine excretion, we say that's no good, because nobody can collect urine reliable for 24 hours. So I think it's much more. I mean, I don't care. Collect the easiest available urine sample and test it for albumin. I think that's, and for most, that's a morning spot urine or a random spot urine. If you have that and it's normal, I think then you are well on way. And if it's abnormal, then you can do something about it, and then you know you have a person at risk. You should repeat it, because there's day-to-day variability. But I mean, don't go for 24-hour urines in everyday clinic. That's too complicated and will not be done. So albumin-creatinine ratio that takes care of this collection issue and is much more handy in the clinic.
So next question, do you follow the ratio with treatment to show that it improves?
We follow that because I think there are many data showing that if you have a reduction in albuminuria, then you're doing something good.
Okay.
Then you are both lowering the risk for cardiovascular and renal outcome on the long term. Just recently there was a publication of, I think it was approximately 30 intervention studies and over 1 million observational data linking changes short-term in albuminuria with long-term benefits in heart outcomes like renal failure or cardiovascular events. So yeah, it's not just about finding patients at risk, it's also about monitoring if your intervention is successful.
So you would go up, say, if somebody was on an ACE or an ARB and you didn't see a change in their albumin-creatinine ratio and their blood pressure could tolerate it, that would tell you that you should increase the dose?
Yeah, I think we worked previously a lot with increasing doses to kind of like beyond what is good for lowering blood pressure. And we saw additional effects on albuminuria, but we have not long-term data suggesting that that really translates into better. So I think what we'd probably rather do today is you put people on ACE or an angiotensin II receptor blocker, and then at least in type 2 diabetes, use the SGLT2 inhibitors or GLP-1 receptor agonists. But for the moment, the best data are with the SGLT2 inhibitors. We just got the Credence study with canagliflozin showing that you reduce renal outcomes in patients with proteinuria and type 2 diabetes. And maybe this would also translate to type 1 diabetes. Now we are beginning to discuss using SGLT2 inhibitors, but that's still, I think, very early days. But to me, it would be more important if we could affect the cardiovascular and renal outcome than lower glucose a little bit, because in the type 1 population. But for type 2, no doubt, I think we are getting more and more data that the SGLT2 inhibitors and also the GLP-1 receptor agonists have good effect in the patients with persistent proteinuria.
Yes, I've been really impressed by the SGLT2 inhibitor data that's been coming out. And Credence, I was thrilled to see that, and thrilled to see that you could use them at a lower EGFR, because that's been my concern as I treat patients. I'm a little nervous about those patients with lower EGFRs in general. And then, I want to be able to use agents safely, but it was pretty impressive that you could use it all the way down to an EGFR of 30. So I think this may be a game changer.
I think you're right. The label are still saying, at least in my country, that if you are below 60, you cannot start SGLT2 inhibitors, and if you are below 45 and on an SGLT2 inhibitor, then you should stop. But as you say, well, the studies go down to around 30 in EGFR. There are no increase in side effect, no increase in acute kidney injury, and the kidney and cardiovascular protective effect seems to be preserved also in this range. And the reason for the targets or for the levels of GFR is more related to the lack of effect on lowering glucose than on side effects. And therefore, the more data we get in that range, I think that will change soon. And I think some countries have already changed the label so that you can use SGLT2 inhibitors down to 30 or so. And that will probably change in many other countries also going forward.
I think it's very interesting. What about the GLP-1 receptor agonists? How do you see their role? I know they have some benefit, and I think it is seemingly less, but we haven't done really head-to-head trials.
We have no head-to-head trials in the renal or cardiovascular arena. We are just about starting a study called FLOW with one of the GLP-1 receptor agonists in a kidney study to see if you can, large outcome study with type 2 diabetes with kidney disease, to see if you can prevent hard renal outcomes in this population with the GLP-1 receptor agonist. And then they are, you can use them to a lower degree of GFR, and they have a cardiovascular protective effect in this population. And there are also data, at least on albuminuria and maybe on GFR as well, that they have good effects in this population at high risk for both renal and cardiovascular problems.
So let me just, in our last minute, bring you back to a patient. So say a person has a patient who's 65 years old and type 2 diabetes and is got albuminuria and is on an ACE inhibitor and a statin, and you see that person, what's the first thing you think or worry about? Do you think about their LDL? Do you think about their blood pressure? Do you think about just adding in more drugs? How do you assess that person?
Well, that's a good question. I think from the STS2 trial, we learned that multifactorial intervention is extremely important in such a person. So we need to address both lipids, blood pressure, and glucose. We need to address smoking if that's an issue. And healthy lifestyle is important as well. Today there was data from Jocelyn showing that also on long-term perspective may impact the kidney in a beneficial way. And then of course I would consider, well, if the patient was on statin, was on an ACE inhibitor, well, probably SGLT2 inhibitor, or if there was existing cardiovascular disease, alternative GLP-1 receptor agonist, or if there's a weight loss desire, that could be an option as well. So I think these new drugs we need to consider. And unfortunately, Friday there was some data from the US by Mikhail Kosiborod published in Circulation Friday also, showing that only approximately 8% are actually treated according to the guidelines. And maybe that's just because the data were collected while the guidelines were being developed. So maybe if you do a new survey, it's hopefully going to improve. But I really think there's a room for improvement that we as clinicians address all the risk factors, because it really impacts survival, cardiovascular events, and renal events in our patients.
Yes, I encourage people to follow the current guidelines, because after metformin, step 2 is to determine if a patient has pre-existing cardiovascular disease, CKD, or heart failure, and then treat those patients differently, perhaps, but also more aggressively for all these risk factors.
Yeah.
Well, so thank you very much for taking the time to talk with us today.